Hello, this is the first Tegrity recording on intracranial pressure. This content is divided into 4 parts. Part 1 will include the concept of ICP and the nursing management. We'll start off with a review of pathophysiology. Understanding the dynamics associated with ICP is important in caring for patients with many different neurological problems. The skull is an enclosed space with 3 essential volume components: the brain tissue, the blood, and the cerebral spinal fluid, or CSF. The intracellular and extracellular fluids of brain tissue make up approximately 78% of this volume. Blood in the arterial, venous, and capillary network makes up 12% of the volume, and the remaining 10% is the volume of the cerebral spinal fluid. Intracranial pressure is the hydrostatic force measured in the brain CSF compartment. Under normal conditions in which intracranial volume remains relatively constant, the balance among the 3 components, brain tissue, blood, and CSF, maintains the cerebral pressure, or the ICP. Factors that influence ICP under normal circumstances are changes in number 1, arterial pressure, number 2, venous pressure, number 3, intra-abdominal and intrathoracic pressure, number 4, posture, 5 is temperature, and 6 is blood gases, particularly CO2 levels. The degree to which these factors increase or decrease the ICP depends on the brain's ability to adapt to changes. The Monro-Kelly doctrine states that the 3 components must remain at a relatively constant volume within the closed skull structure. If the volume of any one of these 3 components increases within the cranial vault, and the volume from another component is not displaced, the total intracranial volume will not change. This hypothesis is only applicable in situations in which the skull is closed. The hypothesis is not valid in persons with displaced skull fractures or hemicranectomies. The ICP can be measured in the ventricles, the subarachnoid space, the subdural space, the epidural space, or even the brain tissue using a pressure transducer. Normal intracranial ICP ranges from 5 to 15 millimeters of mercury. A sustained pressure greater than 20 millimeters of mercury is considered abnormal and must be treated. Applying the Monro-Kelly doctrine, the body can adapt to volume changes within the skull in 3 different ways to maintain a normal ICP. First, compensatory mechanisms can include changes in the cerebral spinal fluid volume. The CSF volume can be changed by altering the CSF absorption or production and by displacement of CSF fluid into the spinal subarachnoid space. Second, changes in intracranial blood volume can occur through collapse of cerebral veins and dural sinuses, also regional cerebral vasoconstriction or dilation, and changes in venous outflow. Third, tissue-brain volume compensates through distension of the dura or compression of brain tissue. Initially, an increase in volume produces no increase in ICP as a result of these compensatory mechanisms. However, the ability to compensate for changes in volume is limited. As the volume increase continues, the ICP rises and decompensation ultimately occurs, resulting in compression of the brain and ischemia. Cerebral blood flow, or CBF, is the amount of blood in milliliters passing through 100 grams of brain tissue in 1 minute. The global CBF is approximately 50 milliliters per minute per 100 grams of brain tissue. The maintenance of blood flow to the brain is critical because the brain requires a constant supply of oxygen and glucose. The brain uses 20% of the body's oxygen and 25% of its glucose. The brain has the ability to regulate its own blood flow in response to its metabolic needs, despite wide fluctuations in systemic arterial pressure. Autoregulation is the automatic adjustment in the diameter of the cerebral blood vessels by the brain to maintain a constant blood flow during changes in arterial blood pressure. The purpose of autoregulation is to ensure a consistent CBF to provide for the metabolic needs of brain tissue and to maintain cerebral perfusion pressure within normal limits. The lower limit of systemic arterial pressure at which autoregulation is effective in a normotensive person is a mean arterial pressure, or MAP, of 70. Below this, CBF decreases and symptoms of cerebral ischemia, such as syncope and blurred vision, will occur. The upper limit of systemic arterial pressure at which autoregulation is effective is a MAP of 150 millimeters per mercury. When this pressure is exceeded, the vessels are maximally constricted and further vasoconstrictor response is lost. The cerebral perfusion pressure, or CPP, is the pressure needed to ensure blood flow to the brain. CPP is equal to the MAP minus the ICP. Normal cerebral perfusion pressure, or CPP, is 60 to 100 millimeters of mercury. As the CPP decreases, autoregulation fails and CBF decreases. A CPP less than 50 millimeters of mercury is associated with ischemia and neuronal death. A CPP less than 30 results in ischemia and is incompatible with life. Normally, autoregulation maintains an adequate CBF and perfusion pressure primarily by adjusting the diameter of cerebral blood vessels and metabolic factors that affect ICP. It is critical to maintain MAP when the ICP is elevated. The relationship of pressure to volume is depicted in the pressure-volume curve. The curve is affected by the brain's compliance. Compliance is the expandability of the brain. It is represented as the volume increase for each unit increase in pressure. With low compliance, small changes in volume result in greater increases in pressure. Compliance equals volume over pressure. The concept of pressure-volume curve can be used to represent the stages of increased ICP. At stage 1 on the curve, there is high compliance. An increase in volume does not increase the ICP. At stage 2, the compliance is beginning to decrease, and an increase in volume places the patient at risk for increased ICP and secondary injury. At stage 3, there is significant reduction in compliance. Any small addition of volume causes a great increase in ICP. As a patient enters stage 4, the ICP rises to lethal levels with little increase in volume. In stage 1, the brain is in total compensation with the combination autoregulation intact. At stage 2, the compliance is beginning to decrease, and an increase in volume places the patient at risk for increased ICP and secondary injury. At stage 3, compensatory mechanisms fail, there's loss of autoregulation, and the patient will exhibit manifestations of ICP such as headache, changes in level of consciousness, or pupil responsiveness. With loss of autoregulation, there's an attempt to maintain cerebral perfusion by the body's attempt to increase systolic blood pressure. However, decompensation is imminent at stage 3. The patient's response is characterized by systolic hypertension with a widening pulse pressure, a bradycardia with full bounding pulse, and altered respirations. This is known as Cushing's triad and is a neurologic emergency. As the patient enters stage 4, herniation occurs as the brain tissue is forcibly shifted from the compartment of greater pressure to a compartment of lesser pressure. In this situation, intense pressure is placed on the brainstem, and if herniation continues to occur, brainstem death is imminent. Carbon dioxide, oxygen, and hydrogen ion concentration will affect cerebral blood vessel tone. An increase in the partial pressure of carbon dioxide in arterial blood, known as PaCO2, relaxes smooth muscle, dilates cerebral vessels, decreases cerebrovascular resistance, and increases CBF. A decrease in PaCO2 will constrict cerebral vessels, increase cerebral vascular resistance, and decrease CBF. Cerebral oxygen tension less than 50 millimeters of mercury results in cerebrovascular dilation. This dilation decreases cerebral vascular resistance, increases CBF, and increases O2 tension. However, if O2 tension is not increased, anaerobic metabolism begins, resulting in accumulation of lactic acid. As lactic acid increases and hydrogen ions accumulate, the environment becomes more acidic. Within this acidic environment, further vasodilation occurs in an attempt to increase blood flow. The combination of severely low partial pressure of oxygen in arterial blood, or PaO2, and an elevated hydrogen ion concentration, or acidosis, which are both potent cerebral vasodilators, may produce a state where autoregulation is lost and compensatory mechanisms fail to meet tissue metabolic demands. Increased ICP is potentially life-threatening and results from an increase in any or all of the three components, brain tissue, blood, or CSF, within the skull. Elevated ICP is clinically significant because it diminishes CPP, and it increases risk of brain ischemia and infarction, and is associated with a poor prognosis. Increased ICP can be caused by many changes in any of the three components. Common causes of increased ICP include a mass, such as a hematoma, an abscess, or a tumor, and cerebral edema that's associated with brain tumors, or hydrocephalus, or head injury, or brain inflammation. These cerebral insults, which may result in hypercapnia, cerebral acidosis, impaired autoregulation, and systemic hypertension, increase the formation and spread of cerebral edema. Cerebral edema distorts brain tissue, further increasing the ICP, and leads to even more tissue hypoxia and acidosis. This figure shows the progression of increased ICP. It's critical to maintain CBF to preserve tissue and thus minimize secondary injury. Sustained increases in ICP result in brainstem compression and herniation of the brain from one compartment to another. Displacement and herniation of brain tissue can cause a potentially reversible process to become irreversible. Ischemia and edema are further increased, compounding the pre-existing problem. This is a slide of what herniation looks like. In A, or the left side of your slide, there's a normal relationship of intracranial structures. But in the B picture, we have a shift of intracranial structures. Compression of the brainstem and cranial nerves may be fatal. Herniation forces the cerebellum and brainstem downward through the foramen magnum. If compression of the brainstem is unrelieved respiratory arrest will occur due to compression of the respiratory control center in the medulla. Cerebral edema is defined as an increased accumulation of fluid in the extravascular spaces of brain tissue. There are a variety of causes, including mass lesions, head injuries, cerebral infection, vascular insults, and toxic or metabolic encephalopathy. Regardless of the cause, cerebral edema results in an increase in tissue volume that can increase ICP. The extent and severity of the original insult are factors that determine the degree of cerebral edema. There are three types of cerebral edema: vasogenic, cytotoxic, and interstitial, and more than one type may occur in the same patient. Vasogenic cerebral edema, the most common type of edema, occurs mainly in the white matter and is characterized by leakage of large molecules from the capillaries into the surrounding extracellular space. This results in an osmotic gradient that favors the flow of fluid from the intravascular to the extravascular space. A variety of insults such as brain tumors, abscesses, and ingested toxins may cause an increase in the permeability of the blood-brain barrier and produce an increase in the extracellular fluid volume. The speed and extent of the spread of the edema is influenced by the systemic blood pressure, also the site of the brain injury, and the extent of a blood-brain barrier defect. This edema may produce a continuum of symptoms ranging from headache to disturbances in consciousness, including coma, which is a profound state of unconsciousness, and even focal neurologic deficits. It's important to recognize that although a headache may seem to be a benign symptom, in cases of cerebral edema, it can quickly progress to coma and death. Therefore, you must, as a nurse, be vigilant in your assessment skills. Cytotoxic cerebral edema results from the disruption of the integrity of the cell membranes. Cytotoxic cerebral edema develops from destructive lesions or trauma to brain tissue, which results in cerebral hypoxia or anoxia and syndrome of inappropriate antidiuretic hormone or SIADH secretion. In this type of edema, the blood-brain barrier remains intact. Cerebral edema occurs as a result of fluid and protein shifts from the extracellular space directly into the cells, with subsequent swelling and loss of cellular function. Interstitial cerebral edema is usually a result of hydrocephalus. Hydrocephalus is a buildup of fluid in the brain and is manifested by ventricular enlargement. It can be due to excess CSF production, obstruction of flow, or an inability to reabsorb the CSF. Hydrocephalus treatment usually consists of a ventriculostomy or ventriculoperitoneal shunt. The patient's state of consciousness is defined by the patient's clinical responses and pattern of brain activity. Level of consciousness is the most sensitive and reliable indicator of the patient's neurological status. Changes in the LOC are a result of impaired CBF, which causes oxygen deprivation to the cells of the cerebral cortex and reticular activating system. Changes in the LOC are a result of impaired CBF, which causes oxygen deprivation to the cells of the cerebral cortex. A change in consciousness may be dramatic, as in a coma, or subtle, such as a flattening of affect, a change in orientation, or a decrease in the level of attention. In the deepest state of unconsciousness, in other words, a coma, The patient doesn't respond to painful stimuli. Corneal and pupillary reflexes are absent. The patient cannot swallow or cough and is incontinent of urine and feces. The EEG pattern demonstrates suppressed or absent neuronal activity. Manifestations such as Cushing's triad may be present, but often do not appear until ICP has been increased for some time or is suddenly markedly increased, as with head trauma. Changes in vital signs are caused by increasing pressure on the thalamus, the hypothalamus, the pons, and the medulla. Manifestations such as Cushing's triad, where there is a systolic hypertension with a widening pulse pressure, bradycardia with a full and bounding pulse, and irregular respirations, may be present but often do not appear until the ICP has been increased for some time or is suddenly and markedly increased, for example, with head trauma. Always recognize Cushing's triad as a medical emergency, as this is a sign of brainstem compression and impending death. A change in body temperature may also occur because increased ICP affects the hypothalamus. Now let's look at eye signs or ocular signs. Compression of cranial nerve 3, the oculomotor nerve, results in dilation of the pupil on the same side, which is called ipsilateral, as the mass lesion or sluggish or no response to light or the inability to move the eye upward and abduct, and ptosis of the eyelid occurs. These signs can be the result of a shifting of the brain from the midline, compressing the trunk of cranial nerve 3, and paralyzing the muscles controlling pupillary size and shape. In this situation, a fixed unilateral dilated pupil is considered a neurologic emergency that indicates herniation of the brain. Other cranial nerves may also be affected, such as the optic nerve, cranial nerve 2, the trochlear or cranial nerve 4, and abducens or cranial nerve 6. Signs of dysfunction of these cranial nerves include blurred vision, diplopia, and changes in extraocular eye movements. Central herniation may initially manifest as sluggish but equal pupil response. Uncal herniation may cause a dilated unilateral pupil. Papilledema, which is an edematous optic disc seen on retinal examination, is also noted and is a nonspecific sign associated with persistent increases in ICP. As the ICP continues to rise, the patient manifests changes in motor ability. A contralateral or opposite side of the mass lesion indicates hemiparesis or hemiplegia, and this may develop due to an increase in the ICP, depending on the location of the source. If painful stimuli is used to elicit a motor response, the patient may localize to the stimuli or withdraw from it. Noxious stimuli may also elicit a decorticate or flexor or decerebrate extensor posturing. Decorticate posture consists of internal rotation and adduction of the arms with flexion of the elbows, wrists, and fingers as a result of interruption of voluntary motor tracts in the cerebral cortex. Extension of the legs may also be seen. A decerebrate posture may indicate more serious damage and results from disruption of motor fibers in the midbrain and brainstem. In this position, the arms are stiffly extended, adducted, and hyperpronated. There is also hyperextension of the legs with plantar flexion of the feet. Here's a great picture to describe decorticate and decerebrate posturing. In Figure A, we have decorticate response with flexion of arms, wrists, and fingers with adduction in upper extremities. Extension, internal rotation, and plantar flexion occurs in the lower extremities. In Figure B, we have decerebrate response. All four extremities are in rigid extension with hyperpronation of forearms and plantar flexion of feet. In Figure C, we have decorticate response on the right side of the body and decerebrate response on the left side of the body. And finally, Figure D is apostonic posturing. Although the brain itself is sensitive to pain, compression of other intracranial structures such as arteries, veins, and cranial nerves can cause a headache. A nocturnal headache and/or a headache in the morning is cause for concern and may indicate a tumor or other space-occupying lesion that is causing increased ICP. We also may have straining, agitation, or movement may accentuate the pain. Vomiting can occur. Vomiting, usually not preceded by nausea, is often a nonspecific sign of increased ICP. This is called unexpected vomiting and is related to pressure changes in the cranium. Projectile vomiting may also occur and is related to increased ICP. The major complications of uncontrolled increased ICP are inadequate cerebral perfusion and cerebral herniation. To better understand cerebral herniation, two important structures in the brain must be described. The falx cerebri is a thin wall of dura that folds down between the cortex, separating the two hemispheres. The tentorium cerebelli is a rigid fold of dura that separates the cerebral hemispheres from the cerebellum. It is called the tentorium, meaning tent, because it forms a tent-like cover over the cerebellum. Tentorial herniation or central herniation occurs when a mass lesion in the cerebrum forces the brain to herniate downward through the opening created by the brainstem. Uncal herniation occurs with lateral and downward herniation, and cingulate herniation occurs with lateral displacement of brain tissue beneath the falx cerebri. Diagnostic studies can be used to identify the cause of increased ICP. A CT or computed tomography and magnetic resonance imaging or MRI are used to differentiate the many conditions that can cause increased ICP and to assess the effective treatment. A PET scan, positive emission tomography, is also used to diagnose the cause of increased ICP. Additional tests include EEG, cerebral angiography, ICP measurement, brain tissue oxygenation measurement through a Lycox catheter, or transcranial Doppler studies and evoked potential studies. In general, a lumbar puncture is not performed when increased ICP is suspected. The reason for this is that the cerebral herniation could occur from the sudden release of the pressure in the skull from the area above the lumbar puncture. In some institutions, a handheld near-infrared scanner or infrascanner is used to detect life-threatening intracranial bleeding. The scanner directs a wavelength of light that can penetrate tissue and bone, and blood from intracranial hematomas absorbs the light differently than other areas of the brain. ICP monitoring is used to guide clinical care when the patient is at risk for or has elevations in ICP. It may be used in patients with a variety of neurological insults, including hemorrhage, stroke, tumor infection, or traumatic brain injury. ICP should be monitored in patients admitted with a Glasgow Coma Scale score of less than or equal to 8 and an abnormal CT or MRI. These results indicate that the patient may have bleeding, contusion, edema, or other problems. Patients with conditions known to elevate ICP usually undergo ICP monitoring in an ICU, except those with irreversible problems or advanced neurological disease. Multiple methods and devices are available to monitor ICP in various sites. This picture shows a coronal section of brain showing potential sites for placement of ICP monitoring devices. The gold standard for monitoring ICP is the ventriculostomy, in which a specialized catheter is inserted into the lateral ventricle and coupled to an external transducer. This technique directly measures the pressure within the ventricles, facilitates removal and/or sampling of CSF, and allows for intraventricular drug administration. CSF can be drained through a ventriculostomy when ICP exceeds the upper pressure parameter that is set by the physician. Intermittent drainage involves opening the three-way stopcock to allow CSF to flow into the drainage bag for brief periods, 30 to 120 seconds, until the pressure is below the upper pressure parameters. Here we have several pictures. Picture A provides a picture of an ICU nurse leveling a ventriculostomy. And in B, we have the drainage system where the cerebral spinal fluid is drained into a drainage bag. And the far picture on the right is a picture, of course, an ear, and an earring is positioned where the tragus is. In this system, the transducer is external. It's important to make sure that the transducer of the ventriculostomy is level to the foramen of Monro, which is the intraventricular foramen, and that the ventriculostomy system is at the ideal height. A reference point for this foramen is the tragus of the ear, noted at the placement of the earring in the right-hand picture. Whenever the patient is repositioned in the bed, the system needs to be re-zeroed and leveled. The fiber optic catheter, which is an alternative technology, uses a sensor transducer located within the catheter tip. The sensor tip is placed within the ventricle or the brain tissue and provides a direct measurement of brain pressure. The air pouch or pneumatic technology is another system for monitoring ICP and has an air-filled pouch at the tip of the catheter that maintains a constant volume. The pressure changes within the cranium are transmitted through the changes exerted on this pouch to the monitor. Infection is, of course, a serious complication with ICP monitoring. Factors that can contribute to the development of an infection include ICP monitoring more than 5 days, use of a ventriculostomy, a CSF leak, and a concurrent systemic infection. The nurse should routinely assess the insertion site, use a septic technique, and monitor the CSF for a change in drainage color or clarity. ICP should be measured as a mean pressure. If CSF drainage device is in place, the drain must be closed for at least 6 minutes to ensure an accurate reading. Intracranial pressure monitoring can be used to continuously measure ICP. The ICP tracing shows normal, elevated, and plateau waves. ICP is represented on the monitor as a mean pressure in millimeters of mercury. The normal ICP waveform has 3 phases. When the ICP is normal, phase P1, P2, and P3 will resemble a staircase. As the ICP increases, P2 will rise above the P1, indicating poor ventricular compliance. During measurement of the ICP, it's important to consider the rate at which changes occur and also the patient's clinical condition. Neurologic deterioration may not occur until the ICP elevation is pronounced and sustained. The nurse should immediately report to the healthcare provider any ICP elevation, either as a mean increase in pressure or as an abnormal waveform configuration. Inaccurate ICP readings can be caused by CSF leaks around the monitoring device or obstruction of the intraventricular catheter or bolt from tissue or blood clots. It can also occur with kinks in the tubing or difference between the height of the bolt and the transducer and incorrect height of the drainage system relative to the patient's reference point. Also, bubbles or air in the tubing can dampen the waveform. With the ventricular catheter, it's possible to control ICP by removing CSF. The healthcare provider will typically order a specific level to initiate drainage. For example, if the ICP is greater than 20 millimeters of mercury, as well as a frequency of drainage, such as intermittent or continuous. When the ICP is above the indicated level, for example 20, the ventriculostomy system is opened by turning a stopcock and allowing this drainage of cerebral spinal fluid, thus relieving the pressure inside the cranial vault. There are two options for cerebral spinal fluid drainage, intermittent and continuous. If intermittent drainage is ordered, open the ventriculostomy system at the indicated ICP and allow cerebral spinal fluid to drain for 2 to 3 minutes. Then the stopcock is closed to return the ventriculostomy to a closed system. If, however, continuous ICP drainage is ordered, we want to carefully monitor the volume of CSF drain and keep in mind that normal cerebral spinal fluid production is about 20 to 30 milliliters per hour, with a total CSF volume of about 150 milliliters within the ventricles and subarachnoid space. It is also recommended that a sign be posted above the patient's bed to notify anyone before turning, moving, or suctioning the patient to prevent the removal of too much CSF, which can result in other complications. Strict aseptic technique during dressing changes or sampling of cerebral spinal fluid is imperative to prevent infection. The system must remain intact to ensure that the ICP readings are accurate because treatment is initiated based on the pressures. Complications of this type of drainage system include ventricular collapse, infection, and herniation or a subdural hematoma formation from too rapid decompression. Now we're going to move on into goals of care. The goals of interprofessional care are, number 1, to identify and treat the underlying cause of increased ICP, and 2, to support brain function. The earlier the condition is recognized and treated, the better the patient outcome. A careful history is a very important diagnostic aid that can direct the search for the underlying cause. The underlying cause of increased ICP is usually an increase of blood, such as hemorrhage, or brain tissue, such with a tumor, or cerebral spinal fluid, such as with hydrocephalus in the brain. For any patient with increased ICP, it's important to ensure that adequate oxygenation is being maintained to support brain function and to prevent secondary injury. Arterial blood gases, or ABGs, guide the oxygen therapy. The goal is to maintain the PaO2 at greater than or equal to 100 millimeters of mercury, and to keep the PaCO2 in normal ranges between 35 to 45. The patient may be intubated or have a tracheostomy to provide adequate ventilation. If increased ICP is caused by a mass lesion, such as a tumor, surgical removal of the mass is probably the best treatment. In aggressive situations, a craniectomy, which is removal of part of the skull, may be performed to reduce ICP and prevent herniation. Drug therapy plays an important part in the management of increased ICP. Mannitol, also known as Osmetrol, 25%, is an osmotic diuretic given IV. Mannitol acts to decrease the ICP in two ways, through plasma expansion and osmotic effect. An immediate plasma expansion effect reduces the hematocrit and blood viscosity, thereby increasing cerebral blood perfusion and cerebral oxygen delivery. A vascular osmotic gradient is created by mannitol, thus fluid moves out from the tissues into the blood vessels. Therefore, the ICP is reduced by a decrease in the total brain fluid content. We also monitor fluid and electrolyte status when osmotic diuretics such as mannitol are used. Hypertonic saline is another drug treatment used to manage increased ICP. It produces massive movement of water out of edematous swollen brain and into the blood vessels. Hypertonic solution requires frequent monitoring of blood pressure and serum sodium levels, as intravascular fluid volume excess can occur. Hypertonic saline has been shown to be just as effective as mannitol when treating increased ICP, and both are often used concurrently when caring for severely brain-injured patients. Corticosteroids such as dexamethasone, otherwise known as Decadron, are used to treat vasogenic edema surrounding tumors and abscesses. However, these drugs are not recommended for traumatic brain injury. Corticosteroids tend to stabilize the cell membrane and inhibit the synthesis of prostaglandins, thus preventing the formation of pro-inflammatory mediators. Corticosteroids also improve neuronal function by improving CBF and restoring autoregulation. Complications associated with the use of corticosteroids include hyperglycemia, increased incidence of infections, and GI bleeding. As a nurse, we want to regularly monitor fluid intake and sodium and glucose levels. Perform blood glucose monitoring at least every 6 hours for any patient receiving corticosteroids until hyperglycemia is ruled out as a concern. Patient receiving corticosteroids should concurrently be giving antacids or histamine 2 blockers such as cimetidine or Tagamet, ranitidine or Zantac, or PPIs, proton pump inhibitors such as omeprazole, Prilosec, pantoprazole, or Protonix to prevent GI ulcers and bleeding. Metabolic demands such as fever greater than 38 degrees centigrade, agitation, shivering, pain, and seizures can also increase ICP. The healthcare team should plan to reduce these metabolic demands in order to lower the ICP in the at-risk patient. Monitor the patients for seizure activities. They may need to be placed on prophylactic anti-seizure medication. Fever should be well controlled in order to maintain a temperature of 36 to 37 degrees centigrade by using antipyretics such as Tylenol or acetaminophen, cool baths, cooling blankets, ice packs, or even intravascular cooling devices as necessary. But we don't want to cause the patient to shiver or shake. Shivering should be avoided, as this will increase the metabolic workload on the brain, and sedatives may even need to be ordered or a different type of cooling method. Manage pain while being careful not to oversedate or medicate. Finally, the patient should remain in a quiet and calm environment with minimal noise and interruptions. Observe the patient for signs of agitation, irritation, or frustration. Also, teach the caregiver and family about decreasing stimulation. Coordination with the interprofessional team is necessary to minimize procedures that may produce agitation. Drug therapy for reducing cerebral metabolism may be an effective strategy to control ICP. Reducing the metabolic rate will decrease the CBF and therefore the ICP. High doses of barbiturates such as pentobarbital or Nembutal, thiopental or pentothal are used in these patients with increased ICP that are refractory or otherwise cannot be treated by other treatments. Barbiturates can decrease cerebral metabolism, causing a decrease in ICP as well as a reduction in cerebral edema. Regardless of their state of consciousness, patients must have their nutritional needs met. Because malnutrition promotes continued cerebral edema, we need to maintain optimal nutrition. The patient with an increased ICP is in a hypermetabolic and hypercatabolic state that increases the need for glucose to provide the necessary fuel for metabolism of the injured brain. If the patient cannot maintain an adequate oral intake, other means of meeting the nutritional requirements such as enteral feedings or parenteral nutrition should be initiated. Early feedings within 3 days following brain injury may improve outcomes. So nutritional replacement should begin within 3 days after injury to reach full nutritional replacement within 7 days after injury. Patients should also be kept in a normal volemic fluid state. We want to continuously evaluate patients based on clinical factors such as urine output, insensible fluid loss, serum and urine osmolality, and serum electrolytes. IV 0.9% sodium chloride is the preferred solution for administration of piggyback medications. If 5% dextrose in water or 0.545% sodium chloride is used, serum osmolarity decreases and an increase in cerebral edema may occur. So let me repeat. IVs of 0.9% sodium chloride is the preferred solution. Now let's look at the nursing assessment. Subjective data about the patient with increased ICP can be obtained from the patient, the caregiver, or the family who are familiar with the patient. Describe the LOC by noting specific behaviors that are observed. Assess the LOC using the Glasgow Coma Scale. It's a quick, practical, and standardized system for assessing LOC. Specific behaviors observed as responses to the testing stimuli are given a numeric value in the Glasgow Coma Scale. Your responsibility is to elicit the best response on each of the scales. The higher the scores, the higher the level of brain function. The subscale scores are particularly important if a patient is untestable in one area. For example, severe periorbital edema may make eye opening impossible. The total Glasgow Coma score is the sum of the numeric values assigned to each of the 3 areas evaluated. The highest Glasgow Coma Scale score is 15 for a fully alert person, and the lowest possible score is a 3. A Glasgow score of less than or equal to 8 is generally indicative of coma, and mechanical ventilation should be considered at that point or even earlier. The Glasgow Coma Scale offers several advantages in the assessment of the unconscious patient. It allows different healthcare professionals to arrive at the same conclusion regarding the patient's status and can be used to discriminate between different or changing status. Although the Glasgow Coma Scale is the gold standard assessment tool for level of consciousness, other scales are also used in the clinical setting. The nurse should do a pupil check for size and response. Compare the pupils with one another for size, shape, movement, and reactivity. If the ocular motor nerve or cranial nerve 3 is compressed, the pupil on the affected side, which is also known as ipsilateral, becomes larger until it fully dilates. If ICP continues to increase, both pupils dilate. Test the pupillary reaction with a pen light. The normal reaction is brisk constriction when the light is shown directly into the eye. Also note a consensual response, which is a slight constriction in the opposite pupil at the same time. A sluggish reaction can indicate early pressure on cranial nerve 3, which is the oculomotor nerve. A fixed pupil unresponsive to light stimulus usually indicates increased ICP. However, it's important to note that there are other causes of a fixed pupil, including direct injury to cranial nerve 3, previous eye surgery, administration of atropine, or the use of mydriatic eye drops. In some hospitals, clinicians are using a handheld device called a pupillometer to measure the pupil reactivity and size. The device removes any subjectivity from pupil evaluation. Evaluation of other cranial nerves can be included in the neurologic assessment. Eye movements controlled by cranial nerves 3, 4, and 6 can be examined in the patient who is awake and able to follow commands, and these can be used to assess the function of the brainstem. Testing the corneal reflex gives information about the functioning of cranial nerves 5 and 7. If this reflex is absent, initiate routine eye care to prevent corneal abrasion. Eye movements of the uncooperative or unconscious patient can be elicited by reflex with the use of head movements, such as the oculocephalic and caloric stimulation. To test the oculocephalic reflex, which is also known as doll's eye reflex, turn the patient's head briskly to the left or the right while holding the eyelids open. A normal response is movement of the eyes across the midline in the direction opposite that of the turning. Next, quickly flex and then extend the neck. Eye movement should be opposite to the direction of the head movement, up when the neck is flexed and down when it is extended. Abnormal responses can help locate the intracranial lesion. This test should not be attempted if a cervical spine problem is suspected and is really normally done by the healthcare providers, physician, nurse practitioner, etc. Test motor strength by asking the awake and cooperative patient to squeeze your hands to compare strength in the hands. The pronator drift test is an excellent measure of strength in the upper extremities. The patient raises the arms in front of the body with the palmar surface facing upward and eyes closed. If there's any weakness in the upper extremity, the palmar surface turns upward and the arm drifts downward. This would indicate a problem in the opposite motor cortex. Asking the patient to raise the foot from the bed or to bend the knees up in bed is also a good assessment of lower extremity strength. You want to test all 4 extremities for strength and evaluate for any asymmetry in strength or movement. The nurse should also assess the motor response of the unconscious or uncooperative patient by observing spontaneous movement. If there isn't any, apply a painful stimulus to the patient and note the response. Resistance to movement during passive range of motion exercise is another measure of strength. Do not include hand squeezing as part of the assessment of motor movement in the unconscious or uncooperative patient, as this is a reflex action and can provide a misinterpretation of the patient's status. The nurse should also record vital signs, including BP, pulse, respirations, and temperature. Be aware of Cushing's triad because this indicates severely increased ICP. Along with noting the respiratory rate, also note the respiratory pattern. This slide shows the variety of different respiratory patterns that can occur with brain injury. Cheyne-Stokes in number 1 shows cycles of hyperventilation with apnea. In figure 2, you show sustained, regular, rapid, and deep breathing. There's apneustic breathing with prolonged inspiratory phases or pauses alternating with expiratory pauses. And then there's cluster breathing, where you have clusters of breaths followed by irregular pauses in between. And then finally is ataxic breathing, where you have completely irregular breaths, with some breaths that are deep and some that are shallow. Nursing diagnosis for the patient with increased ICP include but are not limited to decreased intracranial adaptive capacity related to decreased cerebral perfusion or increased ICP. 2. Risk for ineffective cerebral tissue perfusion related to reduction of venous and or arterial blood flow and cerebral edema. And number 3 is risk for disuse syndrome related to altered level of consciousness, immobility, and altered nutritional intake. Overall goals for the patient with increased ICP are to, number 1, maintain a patent airway, follow the ABCs, have ICP within normal limits, have normal fluid, electrolyte, and nutritional balance, and prevent complications which are secondary to immobility and decreased LOC. We want to maintain respiratory function. Maintenance of a patent airway is always critical in the patient with an increased ICP. As the LOC decreases, the patient is at a risk of airway obstruction from the tongue, dropping back and occluding the airway, or from secretions. In general, any patient with a Glasgow Coma scale less than or equal to 8 or an altered LOC who is unable to maintain a patent airway or effective ventilation needs intubation and mechanical ventilation. We want to prevent hypoxia and hypercapnia in order to minimize secondary injury. Positioning of the head is important. We want to elevate the head of the bed to 30 degrees because this will enhance respirations and decrease cerebral edema. We want to remove secretions by suctioning as needed. We can use an oral airway to facilitate breathing and easier suctioning. We need to remember that suctioning and coughing will increase ICP. We want to keep suctioning to a minimum less than 10 seconds in duration, and we want to give 100% oxygen before and after to prevent decreases in PaO2. To avoid cumulative increases in the ICP with suctioning, limit suctioning to 2 passes per suction if possible. To prevent abdominal distension, we want to insert an NG tube to aspirate the stomach contents. But in patients with facial and skull fractures, a nasogastric tube is contraindicated unless a basal skull fracture has been ruled out, and an oral insertion of a gastric tube is preferred. Pain, anxiety, and fear from the primary injury or from procedures can increase ICP and blood pressure and thus cause complications in the management and the recovery of the brain injured patient. We want to use appropriate drugs such as sedatives, paralytics, and analgesics for symptom management. Administration of these drugs may alter the neurological state and mask true neurologic changes, so it may be necessary to temporarily suspend drug therapy to appropriately assess neurologic status. The choice, the dose, and combination of agents may vary depending on the patient's history, neurologic state, and overall clinical presentation. We may use opioids such as morphine sulfate or fentanyl. We can use IV sedatives such as propofol or Diprivan to help with management of anxiety and agitation. It has a particularly short half-life and a rapid onset. And it's good to use when you need accurate neurological assessments because they can be performed very soon after turning off the infusion. There's also another drug called dexmedetomidine or Precedex, and it's an alpha-2 adrenergic agonist. We don't see that used as much as Diprivan, but it can be used continuously IV for patients who are intubated. We need to be aware of the side effects, especially hypotension, as this can result in a lower cerebral perfusion pressure. We may also consider neuromuscular blocking agents such as vecuronium, also known as Norcuron, or Nimbex. These are useful for achieving ventilatory control and to treat intracranial hypertension. Because these agents paralyze muscles without blocking pain or noxious stimuli, they are used in combination with sedatives, analgesics, and benzodiazepines. Benzodiazepines, although useful for sedation, are usually avoided in the management of the patient with increased ICP because of the hypotensive effect and long half-life, unless they are used as an adjunct to neuromuscular blocking agents. Fluid and electrolyte disturbances can have an adverse effect on ICP, so we want to closely monitor the IV fluids, monitor intake and output, watch the electrolytes, note any abnormal values, discuss them with the healthcare provider, particularly serum glucose, sodium, potassium, magnesium, and osmolality. Also monitor the urinary output to detect problems with diabetes insipidus and syndrome of inappropriate antidiuretic hormone, SI-ADH. Diabetes insipidus is caused by a decrease in antidiuretic hormone, ADH. It results in an increased urinary output and hypernatremia. The usual treatment of DI is fluid replacement, vasopressin or pitressin, or DDAVP, desmopressin acetate. If not treated, severe dehydration can occur. SI-ADH is caused by an excess secretion of ADH. SI-ADH results in a decreased urinary output and dilutional hyponatremia. It may result in cerebral edema, changes in level of consciousness, seizures, and even coma. ICP monitoring is used in combination with other parameters to guide the care of the patient. Valsalva maneuver, coughing, sneezing, suctioning, hypoxemia, and arousal from sleep are factors that can increase ICP, so the nurse needs to be alert to these factors and minimize them. Keep the patient with increased ICP in the head-up position, in midline, and avoid extreme neck flexion. Adjust the body position to decrease the ICP and to improve the CPP. Elevation of the head of the bed promotes drainage from the head and decreases the vascular congestion that can produce cerebral edema. However, raising the head of the bed above 30 degrees may decrease the CPP by lowering systemic blood pressure. Careful evaluation of the effects of elevation of the head of the bed on both ICP and CPP is required. Position the bed so that it lowers ICP while optimizing the CPP and other indicators of cerebral oxygenation. Turn the patient with slow, gentle movements because rapid changes in position may increase the ICP. Pain from repositioning can also increase pressure. Increased intrathoracic pressure can also contribute to increased ICP by impeding venous return. This relates to coughing, straining, and the Valsalva maneuver, so we want to avoid these. Also avoid extreme hip flexion to decrease the risk of raising the intra-abdominal pressure, which will also increase the ICP. We also need to minimize complications of immobility, such as atelectasis and contractures, and we need to protect the patient from self-injury. The patient may be confused, agitated, or may even have seizures, and this will increase the risk for injury. We want to use restraints judiciously in the agitated patient. If we have to use them, they should be secure enough to be effective, and observe the skin area under the restraints regularly for irritation. We may need to use light sedation, as we mentioned before, with drugs like Versed or midazolam or lorazepam, Ativan. Having a family member stay with the patient may have a calming effect. For the patient that is at risk for seizures, we need to implement seizure precautions, which include padded side rails, suction readily available. We want to give anti-seizure drugs on a timely basis and monitor the patient closely. Remember that the patient can benefit from a quiet, non-stimulating environment. In addition to all of these other situations, we want to be aware that the psychological well-being of not only the patient but their families is a priority. The family and the patient may be stressed over the diagnosis or the prognosis. We want to be reassuring in performing care, that we are providing the best care, provide short, simple explanations, and allow the patient and the caregiver to receive answers to the information that they desire. We also need to look at the family members and assist them in having some participation as appropriate, and also have them work with a social worker or chaplain, and of course involve the family in any decision making whenever possible. Our expected outcomes include maintaining intracranial pressure and cerebral perfusion within normal parameters. We want no serious increases in intracranial pressure during or following care, and we want the patient not to experience any complications from immobility. Here's a sample practice NCLEX question. A patient with a head injury has an arterial blood pressure of 92/50 and an ICP of 18 millimeters of mercury. The nurse uses the assessments to calculate the cerebral perfusion pressure, or the CPP. How should the nurse interpret the results? And the answer is B as in boy, the rationale being cerebral perfusion pressure, or CPP, is the presence needed to ensure blood flow to the brain, and CPP is equal to the MAP minus the ICP. The cerebral perfusion pressure, when it's calculated out, is 46 millimeters of mercury. The normal CPP, remember, is 60 to 100. A CPP of less than 50 is associated with ischemia and neuronal death. A CPP of less than 30 results in ischemia and is incompatible with life. So it's critical to maintain MAP when ICP is elevated. And a patient with a head injury may require a higher blood pressure, increasing the MAP and the cerebral perfusion pressure. And this ends part 1 of ICP.